Hello all, hope you're having a great day today. So today we are it's chapter 17, talking about functional movement assessments and exercise programming for apparently healthy participants. So one of the most salient features of successful strength and conditioning programs is progressively overloading the body to the extent that adaptation occurs. This progression is optimized when three fundamental features are present: sensory acuity, optimal stabilization strategies, and mobility. There are, however, a number of pervasive issues, including obesity and overweight, sedentary lifestyles, poor posture, and proper training and aging, that are known to compromise these preconditions of progression. With knowledge of biomechanics, motor control, and optimal alignment, the fitness professional is in position to make the necessary program adjustments and offer lifestyle recommendations to accommodate for these ever-present issues. Ultimately, these accommodations can lay the foundation for optimal gains and functional capacity, strength, and performance. So these are our objectives: to understand the integration of the motor system and the sensory system and developing motor patterns, as well as to examine the importance of stability, mobility, and proprioception within the context of progressive exercise programming, and understand the relevance of optimizing posture for improved neuromuscular function, as well as identify the muscles commonly affected by neuromuscular imbalances, and describing appropriate assessments and exercise prescription. Much like what we did with the functional movement screen, we're going to take it a little bit further this week, and self-myofascial release strategies to improve movement potential. So during the early phases of motor learning, performance is largely under conscious control, meaning a great deal of focus and concentration is needed in order to successfully perform the movement. Upon repeated practice, control of individual movements becomes integrated into motor patterns. These motor patterns are stored in the central nervous system, or CNS, not unlike saving a document on a computer. Once motor patterns are integrated and stored, they become automatic and are fine-tuned by unconscious sensory feedback. The saving of motor patterns makes the neuromuscular system more efficient when the body is exposed to similar demands in the future. For this reason, after sufficient practice, we do not really have to think about riding a bike, hitting a golf ball, or performing a clean and jerk. The problem lies in the saving of faulty motor patterns, as once stored motor patterns can be challenging to correct. So this table is just talking about the salient features of proprioceptive acuity, looking at postural control and how maintaining balance during perturbations, such as a force or gentle tap or vibration, that's applied with the intention of altering our balance. And so looking at each of these and the production of coordinated gait patterns. So an example of that would be biomechanical, efficient walking or running. It's really just looking and monitoring our biomechanics along with that. The sensory system and the motor control system, collectively known as the sensory motor system, work together to control movement, balance, posture, and joint stability. Essentially, in order for optimal movement to occur, the body requires the brain to process afferent sensory information from multiple sources. Dr. Charles Sherrington was the first to characterize this input as proprioception. Currently, proprioception is understood to be the sense of knowing where one's body is in space, and is composed of static or joint position sense and dynamic, such as kinesthetic movement sense. Proprioception enables us with closed eyes to estimate the size of our feet, describe the width of our pelvis, and scratch our noses. So this particular table describes the common movements that are derived from proprioceptive acuity. This sensory input is gathered from specialized nerve endings, termed as mechanoreceptors, that are located within the skin, the muscle, the fascia, and joints. Information collected from visual and vestibular centers further supports proprioception, and when taken together, the result is precise body awareness and well-adapted motor activities. Proprioception is an important mediator of joint stability and mobility, and ultimately the calibration of movement. It follows that this sensory acuity is central to safely perform many of the resistance training exercises that are included in conventional exercise programs. If there are disturbances in proprioception, reactive or feedback, and preparatory or anticipatory feed-forward motor control and stability will be altered, increasing the risk of injury. It is also important to note that problems with stability and or mobility issues will perpetuate proprioceptive deficits. In figure 17.2, it describes the afferent and efferent pathways involved in the sensory motor system. Here you can see the central nervous system is composed of the brain and spinal cord, and it contains relay neurons that of course are gathering information and sending information. The central nervous system receives information from the peripheral nervous system, which is composed of the cranial nerves and the brain, the spinal nerves, and the peripheral nerves and our fingertips. And these contain sensory neurons, like we've talked about within the feet. There are neurons and send information to the body. There is good reason why we prefer driving a car with aligned tires, lug nuts tightened, and fan belts secured. For example, if the fan belt is secured, we have stability. It can move at a very high speed, or mobility for many miles without wear and tear. If these requisite features are not present, we can expect to shell out money for repairs far sooner than the manufacturer originally predicted. We might also expect far-reaching changes to the overall structure and function of the car. The factors that contribute to the mechanical efficiency and the long life of our cars are akin to the features needed for optimal function in the body, stability, and mobility. Here you can see in the picture the brain receives and interprets information from multiple inputs. The vestibular organs inside our inner ear sends information about rotation, acceleration, and position. Our eyes send visual information, and our stretch receptors in the skin send information as well. And here, this is talking about the mechanoreceptors and the non-hairy skin versus the hairy skin. And you've got the different types of mechanoreceptors that calculate different information. And here you can see the major proprioceptive receptors, the muscle spindle and the Golgi tendon organ. Stability has been defined as the state of remaining unchanged, even in the presence of forces that would normally change the state or condition. Others have defined stability as the state of a joint remaining or promptly returning to proper alignment through an equalization of forces. Joint stabilization then occurs through coordinated muscle co-activation, creating a suitable amount of stiffness to maintain joint alignment. So the muscle spindle senses information. It senses that there's too much tension in the muscle, and it will cause a relaxation in that muscle, versus the Golgi tendon organ that senses information and causes a reflex. Stabilization strategies are managed at the subcortical level, where the generation of stability is somewhat automatic and recurs qualitative proprioceptive input. For example, a tennis player does not consciously consider the use of the rotator cuff muscles, the glenohumeral stabilizers, while serving. Rather, the player is more focused on the voluntary actions of the ball toss and the service motion. Ideally, the muscles of the rotator cuff perform the job of joint centration, keeping the humeral head in an optimal position within the glenoid fossa. In an anticipatory manner described as glenohumeral stabilization. To this end, the sensory motor system is responsible for providing awareness, coordination, and feedback to maintain optimal position of the shoulder joint, thereby enhancing the quality of movement and reducing the chance of injury. And here you can see information from the brain. Again, you're getting information from your vision centers as well as the vestibular centers that is sent to the brain and onto the spinal cord and the motor pathways, as well as you're receiving information from the mechanoreceptors. So if the stabilizing rotator cuff muscles are not recruited with proper timing and speed and proper muscle patterns, the humeral head is subject to the pulling forces of the deltoid muscles, which can cause the humeral head to shift upward within the socket. The upward translation is problematic in that several musculotendinous structures, the bicep tendon and the rotator cuff tendons, that are located in this area become impinged between the acromion process and the head of the humerus. Other illustrations of the automation of healthy stabilization strategies are the anticipatory bracing that occurs when a dog unexpectedly pulls on the leash, the bracing of the neck and trunk when cyclist rides over a pothole, or the postural adjustments that are made during abrupt changing directions on the tennis court. So optimal stabilization strategies require that we have a stable base from which forces are transferred, as well as an adequate muscular capacity. So we need strength and endurance. And then we need the proper CNS motor programming, or integration of sensory input, that produces synchronous activation of the muscles. Classifying muscles in this particular way with mobilizers and stabilizers is beneficial for the fitness professional, as stabilizing muscles have unique characteristics, as you can see here, and that the stabilizing muscles are typically slow twitch. They are resistant to fatigue, meaning they have a lot of endurance. They have a tendency to be deep in the muscle tissue, and they are a major contributor to your proprioception. But they have very little force production. It's about stabilization versus force. So they're very prone to weakness, and tend to be more of your muscles for isometric and eccentric actions and joint stabilization, versus your mobilizers, which are more of your fast twitch muscle fibers. They fatigue easily and are very superficial. They also have very little blood flow. They're relatively small due to their proprioceptive role, and they are high in force production. But they are prone to hold excess tension and shorten, which makes them more apt for injury. And they are more of your shortening muscle group, or shortening action, and gross motor movement. Generally speaking, your mobilizing muscles are superficially located and responsible for controlling locomotion, alignment, and balancing forces imposed on the spine. The stabilizing muscles are more centrally located and largely function to create stiffness across joints. These muscles are shorter in length and respond to changes in posture and extrinsic loads. Conversely, mobilizers, or your global muscles, comprise long lever arms, allowing for greater force production, torque, and gross multiplanar movements. Being overweight and obesity is a worldwide epidemic and is associated with elevated risk for a number of chronic diseases such as diabetes, hypertension, and the metabolic syndrome. Among adult men and women, obesity and overweight has been shown to be associated with alterations in motor function and postural control, possibly due to reductions in muscular strength and endurance, postural distortion or discomfort with movement, and the perception of stiffness. Unfortunately, associations of poor motor control and elevated BMI have also been reported in children and adolescents. Moreover, obesity and overweight in growth and developmental stages is believed to contribute aberrant motor patterning, which extends to adulthood. Dr. Valdemar Janda, a key figure in 20th century rehabilitation and one of the first to characterize the sensory motor system, suggested that certain muscles had an inherent propensity for weakening or inhibition, while other muscles were prone to hypertonicity. Ultimately, the tendencies of certain muscles to weaken or tighten may lead to postural distortion and alterations in motor control. This altered regulation of the sensory motor system may occur due to participation in sports involving repetitive actions overtraining, poor ergonomics, sedentary lifestyle, trauma, or disease. Disturbances in the motor control system often follow injury and leave residual effects. In other words, although the client is pain-free, mobility and stability problems and sensory deficits remain. This sets the stage for a perpetual cycle of motor control impairment and mobility and stability limitations. Specifically, these alterations lead to inappropriate magnitudes of muscle forces and stiffness across joints, allowing for a muscle to buckle or undergo shear translation, as described in the rotator cuff example earlier. The loss of stability may be due to damage incurred to the passive structures of the joints, such as the tendons and ligaments, where they can no longer support joint integrity. Additionally, sensory receptors within the joints may be compromised, which will result in the delayed action of stabilizing muscles. The delay in action changes the order of muscle activation that is necessary for joint centration. Saarman proposes that movement impairment stems from a biomechanical cause, in which case repeated movements in one direction or sustained postures result in the remodeling of sarcomeres, whereby muscle lengths adaptively shorten or lengthen. The adaptive shortening represents a loss of sarcomeres, whereas muscle lengthening represents the addition of sarcomeres in a series. Taken together, results in overall muscle imbalance. In effect, we stray from the neutral position and begin to adopt the posture that we are in most of the time. The muscle length adaptations that influence length tension and force coupling relationships, motor control, and ultimately how we are able, or in many cases unable, to move. This set of circumstances is often seen in individuals that are sedentary, where the muscles of the anterior torso and internal rotators of the shoulder tend to shorten. Athletes are also susceptible to development of faulty stabilization strategies and mobility, particularly those who perform repeated, unvaried, or unidirectional movement patterns, such as cyclists or runners, golfers, or overhead athletes. From a performance standpoint, a tight and shortened agonist or primary mover has a lowered activation threshold and is described as hypertonic. This simply means that it will not take much stimulus to activate the muscle, in which case hypertonic muscles suppress or decrease neural activity via reciprocal inhibition. The activity or lengthened agonist and cause further weakening of that muscle. For example, hypertonic iliopsoas muscles often result from repeated hip flexion, as seen in long-distance cycling or running, or from prolonged seated postures. The hypertonicity of the hip flexors then contributes to the progressive weakening of the gluteus maximus via reciprocal inhibition. The gluteus maximus is an important hip extensor. Thus, when forceful hip extension is necessary, the hamstrings, a synergist of the gluteus maximus, will compensate for the weakened gluteus maximus. The compensatory pattern is problematic for two reasons. First, the pattern overworks the synergist, in this example the hamstrings, which increases the risk for injury. Second, that compensatory pattern becomes etched within the sensory motor system and will alter quality proprioception, mobility, and stability. These alterations then tend to perpetuate further postural distortion. They exert a downward force upon the proximal attachment site at the ischial tuberosity of the pelvis. This force rotates the pelvis posteriorly, which reduces the neural curvature of the lumbar spine, or flattening the low back. Mobility and stability are partly derived from the articular geometry, or the shape and depth of joints. It is important to realize that some clients will present with structural anomalies that will prohibit full range of motion, or ROM, on certain exercises. For example, an individual's hip joint may have a capsular structure that prevents performing a deep squat with the feet pointed in a neutral position. In such cases, the fitness professional should encourage movement that is more comfortable for the client and not attempt to stretch through this non-modifiable limitation. The adverse effects of aging on proprioception, stability, and mobility are well established. This is particularly relevant for the fitness professional, as the percentage of individuals over the age of 60 years of age continue to increase in the risk of falls due to diminished kinesthesia, and postural control increases with age. These factors highlight the functional significance of balance and stability training in older population. The reasons behind proprioceptive decline in the elderly include a reduction in the number of joint mechanoreceptors, changes to the structure and sensitivity of mechanoreceptors, inadequate processing of proprioceptive input within the CNS. We will be continuing our conversation in our next session with Chapter 17. We're going to be looking at what is the neutral position and why it is so important. I thank you for joining me today. I'll talk with you soon.